Thank you so much, Dr. Tapp. Appreciate that very much. Before we kick off to our next speaker, a couple of things came up in housekeeping that I probably should have mentioned, but I thought I'd at least take a break here and mention it. It has been asked, how do you chat directly to somebody else on the conference? And if you go up to the Who's Online on the conference site, you can then see who all is in attendance and you can chat directly with them. The second thing that was asked that I think is a good call out that we should make across the board is, can we share these slides on social media or with others? And we do ask that you do not share the slides. We will be consolidating the information and getting out some really good just summary after the day today and also on the 22nd. So thanks for the great questions and comments that are coming in. Now I am really excited to introduce our next speaker, Dr. Antonescu. And she is also an additional person who has graciously supported the EHE Foundation and acts as the lead researcher on the CZI grant. I am thrilled to welcome Dr. Antonescu, also with MSK. She has pre-recorded her presentation on pathologic and molecular subsets. We will watch the presentation, but the wonderful news is she is here and available after for Q&A. So if we can go ahead and kick this off by playing the video, that'd be great.
Good morning, everyone. Thank you, EHE Foundation, so very much for organizing this event and for the kind invitation to participate. I will take the opportunity for today's talk to provide a brief update on the pathologic and molecular subsets of EHE. According to the latest WHO classification, EHE represents a malignant vascular tumor of low to intermediate grade, distinct from other epithelioid vascular lesions such as benign epithelioid hemangioma and high-grade angiosarcoma. As the predominant variant, I will spend most of my talk on classic EHE, characterized by WWTR1 CAMTA1 fusions, and only briefly discuss the other less common genetic variants. EHE was first reported 25 years ago in an abstract by Dale and Lebo under the name of intravascular bronchoalveolar tumor, or IVBAT, and thought to represent an epithelial neoplasm of alveolar origin characterized by these plaques of tumor cells filling the alveolar spaces. Only 7 years later, Weiss and Enzinger used the name EHE, recognizing its ultrastructural features of endothelial lineage. They also further correctly acknowledged its intermediate behavior between benign hemangioma and high-grade angiosarcoma. EHE is a disease of young individuals, half occurring in patients less than 40 years of age. From our molecularly confirmed EHE database, the most common sites are lung, soft tissue, and liver. EHE can present either as a solitary lesion, often in the soft tissue, or with local regional metastases as multiple nodules within one organ, or systemic metastasis and multi-organ involvement. EHE displays certain pathologic features which are unique from other vascular tumors. First, EHE may show an intraluminal or angiocentric growth involving small to large caliber vessels, typically veins being one of the explanation of multifocal, multi-organ involvement. Microscopically, classic EHE show diffuse growth pattern lacking the lobular architecture seen in hemangiomas. Moreover, no mature vascular channel formation is present, which further distinguishes classic EHE from its mimics. Instead, EHE show abortive intracytoplasmic lumina known as blister cells. EHE also show a distinctive stromal component not seen with other vascular tumors, which varies from chondromyxoid, hyaline, to myxoid. Importantly, classic EHE lack extravasated blood, a common feature seen in other vascular neoplasms. EHE is not only heterogeneous at the microscopic level, but also at the clinical level with various presentations even within an individual organ. In the lung, for example, the most common presentation is the so-called IV bat picture, with numerous small nodules mimicking granulomatous or metastatic disease. These solid nodules have a chalky white cut surface and microscopically may have well-defined borders, resembling the initial images by Dale and Lebo with tumor plaques filling the alveolar spaces. The second common presentation is the pleural involvement, which can be diffuse, as seen in this dramatic example encasing the entire lung requiring a pneumonectomy. Or more patchy involvement of variable thickness, in some cases showing extension into the lung parenchyma along the septa or fissures. The pleural EHE involvement may be deceptively bland, resembling fibrous plaques and inflammatory processes, or may show overt sarcomatous growth, mimicking either sarcomatoid mesothelioma, sarcomatoid carcinomas, or other sarcomas such as angiosarcoma. In a smaller subset of cases, EHE can present with a mixed parenchymal and pleural involvement as shown in this PET scan. Patients with hepatic EHE present with multiple nodules. Microscopically, the diagnosis may be challenging as it may mimic fatty change or fibrosis in small biopsy samples. Intravascular spread within medium and large-sized vessels, as well as within hepatic sinusoids, is quite typical. A subset of patients with extensive liver-only disease have been managed with liver transplantation. However, recurrences in the allograft are well documented, as shown in this particular patient who recurred 3 years after a transplant. Histologic grading of EHE remains controversial and not universally accepted by sarcoma pathologists. However, the 2020 WHO classification proposed, at least for soft tissue EHE, a low and high risk of malignancy based on nuclear pleomorphism, mitosis, and necrosis. The risk stratification remains challenging as there are no validated histologic criteria, and various adverse factors depend on the specific clinical presentation. Organ-specific prognostic factors include size and mitosis for soft tissue, pleural involvement for lung EHE, necrosis in liver, and so on. However, in most cases, a separation between a low-risk EHE composed of these bland epithelioid cells and a high-risk EHE can be easily discerned. High-risk EHE typically shows significant nuclear pleomorphism, increased mitosis, and necrosis as shown in these images. When we look at all comers, EHE has the prognosis of a low-grade sarcoma with 90% 1-year and 73% 5-year survival, as reported in this old internet-driven patient registry published in Chest in 2011. However, it became obvious, even from this initial study, that there was a clear dichotomy in clinical behavior, with one group of patients defined as having unconstrained growth showing a 25% 5-year survival. Our recent series of 93 patients with confirmed molecular diagnosis provided a better view of the clinical heterogeneity. First, it showed that soft tissue EHE have the best outcome, with 100% survival being mostly solitary lesions and cured with surgical resection. In contrast, patients with lung EHE had only 49% 5-year overall survival. Dissecting further within the thoracic presentation, EHE with pleural involvement had even worse outcome, with only 22% of patients being alive at 5 years, similar to high-grade sarcomas such as angiosarcoma. Most of what I covered so far relates to classic EHE, characterized by WWTR1 CAMTA1 fusion, which was reported in 2011 by two back-to-back papers from Brian Rubin and our group, respectively. As other talks later today will cover the pathogenesis of this fusion, I will not further discuss, only to mention that the analysis of the WWTR1 CAMTA1 breakpoints in multifocal liver EHE gave us the opportunity to confirm their monoclonal origin and provided evidence that the local regional confinement of intravascular spread is the result of metastatic implants of the same neoplastic clone rather than a field effect. In 2013, our lab identified a subset of EHE harboring YAP1 TFE3 fusions with a different morphologic appearance, with overt vasoformation, as shown here, and strong TFE3 overexpression. Clinically, however, this subset shares similar presentations with classic EHE, with multifocal or multi-organ spread, as shown in this patient, with micronodular opacities throughout both lungs as well as liver disease. Microscopically, also showing nested or vasoformative tumor involving liver, lung, and lymph node metastasis and strong nuclear positivity for TFE3. In our initial study, we reported on 10 cases, showing a young age at presentation with a mean of 30 years of age, common sites involving soft tissue and lung, having a distinct histology and indolent behavior despite a high metastatic rate. In our subsequent recent series, limited to MSK experience, we confirmed most of the initial findings and showed that YAP1 TFE3 EHE have a 5-year survival of 86% compared to WWTR1 CAMTA1 of 58%, although the difference was not statistically significant due to too few cases. Last year, we described an additional molecular subset harboring WWTR1 related fusions, including the WWTR1 MAML2 fusion. These tumors had a predilection for the heart, often in the left atrium, but other locations as well. The morphology was similar to classic EHE, revealing both low and high risk phenotypes as shown in these images, and having a propensity for fatal outcome. 2 patients in our series succumbed of disease within 15 months of diagnosis. From a mechanistic point of view, it is fascinating that both YAP1 and WWTR1 represent effectors of the Hippo pathway, which will be covered in details by other speakers. With the help of the EHE Foundation funds, our future directions are to examine large genomic data sets for transcriptional signatures of different clinical and pathologic subsets, as I presented today, in an attempt to unravel both novel prognostic markers that are currently lacking, as well as therapeutic target for these patients. And with this, I want to thank you very much for your time, and I'm happy to take any questions.
Thank you very much for that presentation. Just a few questions to start off, and I think we'll probably see more coming in as I'm going through these questions. EHE has had a history of having many misdiagnoses. Do you have a feel for some steps that might be taken based on what you are aware of today that might help reduce the number of misdiagnoses?
Before, I guess we identified the recurrent gene fusion, the WWTR1 CAMTA1 My biggest challenge was to distinguish the malignant or grade 2 EHE from angiosarcomas, especially in the pleural mediastinal presentation. And nowadays, if I get a small core biopsy and it's unclear the morphology, then immediately I go to either FISH or Archer targeted RNA-seq to confirm the fusion and have a direct confirmed diagnosis. In places that do not have the molecular tools that we have here, there are now immunohistochemical markers, which are surrogates for these fusion genes. CAMTA1 nuclear expression has been shown in a couple of papers that is very reliable. That would be positive in EHE and will be negative in other vascular mimics. TFE3 nuclear reactivity can detect the YAP1 TFE3 EHE subset, although this antibody is not so robust compared to CAMTA1 and specific in EHE. So there are still some tools available even in smaller community hospitals that can be applied, but I have to fully agree with Bill that at some point these cases have to be referred to a tertiary center and confirm the diagnosis and be discussed at the EHE or sarcoma DMT program.
Got it. Thank you very much. Follow on, or we got a question coming in here, identifying that, now that we're seeing some of these clinical differences, whether, it's at the DNA level or at the histology level, how is that information being used to move towards targeted therapies?
Well, first of all, the fusion is present in 95% of the cases, right? So the fusion is a diagnostic marker, definitely not telling us necessarily which patients will need more systemic chemotherapy or observation. So we are using the fusion for diagnostic, and then we rely on these large series that we have done to incorporate, for example, pleural involvement, lymph node metastasis, histology, all these additional adverse factors weigh in to select which patients may require observation versus a more aggressive treatment. Then, of course, if we look at additional secondary genetic hits, and there will be a talk later today on that, I guess those markers may inform possibly for certain drug choices, or to select patients that will progress more aggressively and therefore will be at need of systemic therapy.
Excellent, thank you. We've gotten a similar question for the previous speaker I was not able to ask, so I will ask you. This may be a challenging one because I don't know if there's an answer or not, but do you have any feelings or recommendations about COVID vaccines as it may pertain to EHE patients?
No, I don't see why wouldn't they be candidates for the vaccine. Maybe Bill can comment on that, if maybe treated with mTOR inhibitors, or I don't know why would that be an issue. To be honest,
Okay.
I don't know.
Yeah, and I know it's early with vaccine treatment, so it's hard to say. I know no one has clearly studied that point yet. Another question that came in here. Can you please speak to the relevance of ground glass opacities in the lung?
Yeah, that's part of the IV BAT granulomatous or miliary type lung involvement. And Microscopically, we see these more nodular or slightly diffuse infiltrates within alveolar spaces, as I thought I clearly illustrated, that translate radiographically in the ground glass appearance. And I guess for a clinician that may not be familiar with the thoracic EHE may be confused with a different process, non-neoplastic.
Thank you. And now, it was clear from your talk that we're seeing a lot of distinctions in histology within this disease class. Is there a good feeling at this point whether those differences are due to genetics, due to the environment in which the tumor is growing, or other factors?
I believe, for example, in the pleural environment, pleural involvement, we see a distinct morphology with EHE. It looks very different than soft tissue EHE, which has classic appearance in the pleura. EHE looks like a sarcomatoid process, as I mentioned and shown, that can easily be missed for mesothelioma or sarcomatoid carcinoma or even a spindle cell sarcoma. So clearly we see differences in morphology based on the anatomic site where the tumor originates or involves. We also see difference in morphology, obviously, with the fusion type. The TFE3 fusion has a completely different morphology. It's able to form vessels and has a bloody background, doesn't have the stromal component that we see in classic EHE. I can't say that I see any difference between EHE with secondary genetic events. Maybe I have not seen enough. I have seen only one case which progressed to a high-grade sarcoma, like a dedifferentiation process, after 17 years of progression, local recurrence after local recurrence. In the end, it transformed into a very high-grade anaplastic process. So we've seen some differences in morphology depending on location and fusion type.
Excellent, thank you. And kind of related to that, are you seeing new variations with new patient samples coming in that are causing you to continue to evolve your analysis and the types of diagnostic analysis you're making?
We evolve every day, okay? It's not one single day I come to work and I don't see something I've never seen after 20 plus years of being a sarcoma pathologist. So we keep our minds open and we are humble about what we see. There's never said, oh yeah, I know everything about EHE. That's not how we approach things. We always see something new, including in EHE. If something is unusual, we try to test it molecularly as deep as we can, at least FISH, Archer, and if possible to do a whole transcriptome and so forth. So yes, we see novel cases. That's how we picked up this new translocation in the heart. Yes, we tested for a regular 1-3 translocation for the WWTR1 CAMTA and it was negative. So yeah, that's how we learn new things, by going through the routine. We look at it, we confirm the fusion. If it's not positive, then we send it for a more in-depth molecular analysis.
And kind of related to that, do you foresee a time in the near, mid, or long-term future where we'll have analyzed enough samples to have what would be a reliable diagnostic?
I think with diagnosis, we are doing okay now. 99% of the cases we have the tools to be comfortable to diagnose, but with all these different subsets, we need a few more years to accumulate cases in order for us to be confident on what regimens, therapy, chemotherapy, or observation we offer to these selective groups. I don't think we are there now. It's such a rare disease that we are just sketching a little bit, like for soft tissue, maybe EHE, we have an idea. Maybe with liver EHE, we have an idea, but we are still struggling with the thoracic lung pleural EHE, what to do with these patients. So I think studying more cases will give us a better insight on how to approach these cases.
Thank you much. And a question just came in. As awareness of this disease increases, are you seeing a higher referral pattern? In other words, to a sarcoma center of excellence, and what education can be done to increase that referral pattern, in your opinion?
Yes, we see more cases. We always saw a number of cases of vascular tumors at Memorial because we have such an excellent surgical and medical oncology sarcoma group. But yes, I guess after we established the EHE excellence at Memorial and our paper came out, we see more cases. I see more consultations from all over the world. And I guess being visible, publishing our experience, participating at these forums at ESMO, and talking to associations like yours is the way that we can put the word out there that this is a rare disease, difficult diagnosis, and we need all our smart heads together and all the molecular tools to make some progress in this disease.
Excellent, thank you. And in terms of the testing, it seems like the centers are doing sort of their own, I think what I'd call homebrew testing. You're using your own facilities to do some of these unique molecular tests. There's not commercial kits available for this disease at this point. What is, if you have a ballpark feel for that, what is the cost of that? And do you think that's a feasible cost to be able to do kind of generally across the entire patient base, or is this an area where we're going to need some improvement?
So we have homegrown fish probes that will be the cheapest way to test and diagnose DHE for both genes. I don't know if they will become commercially available. However, the Archer, the targeted RNA sequencing, is done in most academic places, and I believe maybe the price is 1,500, and it's not just for this fusion. Looks at 64 genes that are involved in all sorts of fusion, so it's a more wider capture. And or foundation medicine, for example, which is definitely more expensive because offers RNA and DNA based targeted sequencing. So there are there are places that can offer different tools for diagnosis. Still remains expensive. We have never turned a patient or a pathologist or clinician away if they don't have the means to pay. I have always tested for free for fish, for example. So, I mean, there are still ways. If anybody has a problem issue with the diagnosis, we could, work things out. And with the, obviously the grants that we obtain from the EHE Foundation has supported our continuous work on EHE. So I am a very strong advocate of molecular confirmation of this diagnosis. It's too important for these patients. They're young patients, and at this day and age, we have to be certain on the diagnosis up front.
All right, one last quick question, and this is going into hypothetical land. If you were given unlimited budget to pursue a project that you're not pursuing right now with respect to EHE, what would you want to do in the next year?
Well, thank you for, I guess, the offer, generous offer, whoever is proposing an open budget. That has not been our constraint over the years. Money has been more space in New York. I have a very small little lab, so I don't have enough space to put more people work on EHE, and also my time that it's half clinical, half so-called research, which includes weekends and, basements. Um, there are so many other things, but yeah, we are doing quite a bit in EHE trying to get in vitro models, right? We are using the CRISPR-Cas9 to put these two major fusions, the CAMTA and the TFE3, into human embryonic stem cells. So we are doing things, but everything takes time in research, and it's not overnight. So thank you for the budget, but I would also need your patience in order to provide more data. We are working on it, and we are really grateful for all the support and that you've been giving us.
Well, thank you so much for your time today.
Sure, my pleasure.